Thank you. I'm trying to find the right place here. Thank you for coming tonight. My name is Judy Campbell, and I'm with the College of Nursing. I want to thank everybody for coming. This is sponsored by both the American Diabetes Association and the College of Nursing. Back in January, I decided to create a team for the Tour de Cure and met Hannah, who is now living in Oklahoma doing stuff with the Tour de Cure down there and American Diabetes Association. And when I met Hannah, I was kind of telling her some of the things that we wanted to achieve through the Tour de Cure. And we decided that it'd be really cool if we could offer an educational series that talked about diabetes and being able to reach students and community members about living with diabetes, what's going on, and with research and with providers, nurse providers. So today we are going to talk about diet and exercise and diabetes. And we're really excited because we have some great people to talk. We're going to start with Dr. Eckel, who Nicole will here in a second introduce, and then Stacy Segelke, who is with endocrinology over at the University of Colorado Hospital. And then we have two panelists. It was never my intention to be a panelist, but I am a person who does exercise a lot, and this is how I control my type 2 diabetes. So I will start by turning it over to Nicole.
Thanks, Judy. So I'm Nicole Meyer. I'm with the American Diabetes Association here locally. I'm really excited to be able to put on an event like this. I'm honored because we actually have a national board member who is also a professor and a researcher here at the University of Colorado. That's Dr. Eckel. So he actually focuses his research on the relationship between exercise and metabolic syndrome, including diabetes. And in his practice, he looks at metabolic syndrome and its relationship to cardiovascular disease. So he's here to give you guys a little bit of insight, and please join me in welcoming. Thank you, Dr. Eckel.
Okay, thank you. All right, so I think I just knocked it over here. So I don't think I need this. So I'm not quite sure how to introduce kind of what I need to say here today, but let me just say this, is that I've been here for over 35 years now on the faculty of the College of Medicine. And my research has really been very interested in nutrition aspects of diabetes, but also nutritional aspects that relate to cardiovascular disease. And in fact, I had the privilege with John Jakisik, who's an exercise scientist at the University of Pittsburgh, to co-chair the lifestyle guidelines for prevention of cardiovascular disease as part of the American Heart Association, the ACC. So that's a document that's about a year and a half old now in press. And so you can go turn to the circulation or the Journal of the American College of Cardiology document that relates to lifestyle and ultimately prevention of cardiovascular disease. Now, when you think about prevention of cardiovascular disease, you think a lot about diabetes because ultimately patients with both type 2 and type 1 ultimately leave this earth ultimately from cardiovascular disease. 2/3 to 75% of deaths in diabetes, either type 1 or type 2, are due to cardiovascular disease. So I'm going to just use that as kind of a framework. Now, my science over the years, both clinical research and patients with or without diabetes or obesity or after weight reduction, and in the laboratory have related to how body fats are partitioned. In other words, we eat fat in the diet and we make fat in the liver. But ultimately, what I've been interested in mechanistically and in human subjects in terms of their ability to lose weight and maintain the weight relates to how fats get metabolized. Either they're oxidized in muscle or they're stored in adipose tissue as fat. So we've been very interested in that process and how nutrition relates to this. Ultimately, macronutrient composition, meaning carbohydrate, fat, and protein, and ultimately how calories relate to this. So I think in a kind of a summarial way, our clinical research relates to after people lose weight, that ultimately that weight reduction is responded to by the body in a way to regain the weight. So, losing weight's hard enough to begin with, but keeping it off is a whole different agenda. And the reason for that is not just willpower and the psychology and behavior of weight reduction. There's a biology that actually returns weight to normal if, in fact, the lifestyle's change. So I think in terms of that research in human subjects, we find that the enzyme that takes fat up to burn it is reduced after people lose weight, and the enzyme that takes fat up and stores it in adipose tissue is upregulated for weight loss. So there's a biology of returning body weight back to the baseline weight after there's an effective weight reduction. So it's just not willpower and behavior. In fact, there's a biology that drives that. Now, you still have to become less active and eat more calories to regain the weight, but the biology is there to store the fat rather than to burn it. So this has been a very active area of research in human subjects over many, many years here. And also in our animal work, this has been a focus of how the enzyme that metabolizes fat in the tissues is regulated by weight and by metabolic conditions such as diabetes. Now, as a clinician, my clinic, despite being an endocrinologist or a diabetologist, my clinic is in the cardiovascular clinic, because as a clinician, I think of prevention of cardiovascular disease. And I see a lot of people with metabolic disturbances such as metabolic syndrome, which is really basically insulin resistance, and with diabetes under reasonably good control or not so good control. And I see patients with type 1 and type 2. So my focus clinically is always to begin with lifestyle. And in fact, I had the privilege of being president of the American Heart Association a decade ago, and my presidential address related to the 3-minute lifestyle questionnaire that we deal with. Every patient I see gets at least 3 minutes of lifestyle evaluation. And that's not smoking and alcohol, which is part of it. But it's really how many fruits and vegetable servings do you have a day? How many servings of whole grains do you have a day? How many fish servings per week? Have you ever tried to lose weight? If you have, what's been successful, what's not? Are there limitations to physical activity? How many steps do you take a day? If you don't have a step counter, why don't you have one? Have you ever tried to be more active and failed? In other words, we go through all of these kinds of questionnaires with our patients, and the idea that being physically active and eating a heart-healthy diet is important in prevention of cardiovascular disease. Now, not only is it in prevention of cardiovascular disease, but adequate weight maintenance and physical activity is important for prevention of type 2 diabetes also. So this is an area clinically I'm very involved in, and being co-chair of the lifestyle guidelines for the AHA makes me even more conscious of the importance of an effective lifestyle. Now, sure, we use drugs to treat type 2 diabetes. There are now 13 classes of FDA-approved drugs to treat type 2 diabetes. And if you add the number of insulins that are available, there are 19 different classes. Now with all the combinations, it could be 21 or 22 with some of the insulin GLP-1 agonist combinations. So we have a lot of drugs to use to control type 2 diabetes, but that doesn't mean that we need to dismiss a healthy lifestyle. So that's an important part of management of patients with type 2 diabetes and also with type 1. And you're going to hear from many others here how important considerations are for management of type 1 diabetes with exercise and diet that relates to glycemic control and ultimately avoidance of hypoglycemia. Michelle's a great example of this, being a marathoner with type 1 and an insulin pump. So let me just comment just very briefly on my basic science, and then I will leave this up to you, Judy, to steer it in whatever direction you want to go. And I'm here to answer any questions you might have. And you got other very, very, good people here to help you answer your questions. But my basic science recently is turned to the brain. And the reason that we've turned to the brain is that this same system of triglyceride metabolism that relates to how lipids are funneled to fat versus muscle, that same enzyme system's in the brain. And we have a very interesting finding in one of our mouse models that has been genetically modified. So what we've done is we've taken an approach to make a mouse that doesn't make this protein that metabolizes fat in the brain, in the neuron. And these are the cells that convert, information to every process that relates to neurofunction. So when we've done this, we've had a very interesting finding. If we knock out this protein in the brain, in the neuron, the animals get fat. And if we have a homozygous, that means both genes have been knocked out, both from mom and from dad. These animals get fat really quickly without a high-fat diet. This is on chow. But if we have just one allele that's knocked out, meaning a deficiency in one gene but not the other one for this enzyme, they also get fat, but they have a delayed onset of obesity. Now, here's what's interesting from a diabetes perspective, is that despite being obese, as these animals age, their glucose metabolism is markedly improved. So we've identified a protein that's made in brain cells and neurons that ultimately, though it processes lipid when it's not there, the lack of processing this lipid relates to better glucose tolerance and prevention of diabetes. Now that's kind of an oxymoron. Obesity is probably the greatest risk factor we have for type 2 diabetes. But how to control obesity, the bottom line is prevent it to begin with. So it's the best strategy for dealing with prevention of type 2 diabetes is preventing obesity to begin with. Because if we could change the obesity epidemic that we have, we'd see the incidence and prevalence of type 2 diabetes falling off substantially. So back to the animal. So this animal, despite being obese, has better glucose tolerance. And what we've done working with a neuroscientist at Tulane University in New Orleans is we've identified nerve fibers that go from the liver to the area of the brain that controls food intake that relate to this enzyme, lipoprotein lipase. So we're on track with identifying a pathway by which fat sensing in the brain controls glucose metabolism peripherally. This is exciting because potentially this is a drug target that could relate to not only maybe modifying weight regulation. We wouldn't want to knock it out entirely at all the neurons, but the idea of better glucose tolerance in the setting of obesity could be a therapeutic target to follow. So that's all you'll hear about my basic science. I'll say one final thing about my last clinical research project probably ever. Although I'm involved in a lot of drug trials using these new drugs to lower cholesterol and heart disease risk. In fact, we're submitting a paper today on one of the PCSK9 inhibitors, which is a very potent cholesterol-lowering agent. It goes beyond statins. But my last kind of clinical investigation study was using the weight loss drug phentermine. And for about 15 years in the clinic, I'm not sure how many of you know this story, but there used to be a drug combination called fen-phen. And phentermine has lived on. It's a generic drug, doesn't cost very much. And then fenfluramine was taken off the market. Well, I was a big user in the 1990s of the combination. And I thought people lost a lot of weight. They did very well. So when fenfluramine got taken off the market, I said, I wonder if phentermine alone works, because there hadn't been much done on this. This has been a generic drug for many, many years. So what I did is over about a 12-year period, 12 to 15-year period, started asking one simple question: do you eat because you're hungry? And when people said they had no hunger-motivated intake and they were given phentermine, there was no weight reduction. But when people ate because they're hungry, most people lost not only a little bit of weight, but quite a few weight. Not people on phentermine now for up to 20 years with like 20% weight reduction, some of them. I mean, it's amazing how effective the drug is in some people. So if you ask me, I would say 40% of the people I see with obesity or type 2 diabetes that need to lose weight eat because they're hungry, mostly hunger-motivated food intake. I would say 40% of people have almost no hunger-motivated food intake who need to lose weight. And then there's that 20% I'm not quite sure. So I might do a phentermine trial on them. So this last study I did, I quit being anecdotal, meaning just not only my experience with phentermine, but I proposed a study where you used validated questionnaires. I work with Mark Cornier, a colleague of mine, and Liz Thomas, an endocrine fellow. We teamed up on this, and we actually proved what I was observing for many, many years. So we have a paper that's now been published, wherein I think if you don't eat because you're hungry, I don't give you phentermine. But if you eat because you're hungry, I'm going to predict a successful weight reduction. And we can talk more about diet and exercise and weight management. I've been in that space for some time, but I'm going to let other people maybe address that too. But that's probably my swan song for clinical investigation. I'm really very focused on my laboratory work right now. So Judy, that's all I'm going to say right now.
Can you answer the difference between type 1 and type 2 diabetes physiologically and treatment?
Sure. Okay, so type 1 diabetes is an autoimmune disease. That means you destroy yourself, but here it's very specific to the beta cell. Although we know that people with type 1 diabetes have other autoimmune disorders, like celiac disease and thyroiditis and other things. So over a period, what used to be thought, a very short period, which is now up to years of the honeymoon period, or actually the precursor period before the honeymoon period. So type 1 diabetes is now often evaluated up front in families wherein there's already type 1 diabetes, because being an autoimmune process, we can measure antibodies that are directed against the beta cell, which is the cell in the pancreas that makes insulin. And those antibody titers, when there's just 1 out of 3 antibodies positive, the likelihood is low. But if there are 2 and 3 and high titers, meaning lots of these antibodies, the onset is usually earlier and can be more sudden. Now, so this period of pre-diabetes, if you will, for type 1 can again be months or it can be years. And it relates to how much autoimmunity you have against the beta cell. Patients with type 1 diabetes require insulin for life. Now, the honeymoon period is a period where the beta cell may recover a little bit after the diagnosis, but that's typically no longer than 6 to 12 months. It doesn't last very long, and then ultimately insulin is required. Now, 2 of us up here have type 1 diabetes. I've had type 1 diabetes now for 63 years. In fact, if I look at people who were diagnosed in the 1950s, 70% are dead. The fact that I'm talking to you here today, I'm not sure what it's due to, but I'm still alive and kicking. So, what's that? And kind of maybe ornery. Stacy said that. We'll talk privately a little later, okay? So anyway, type 1 is an autoimmune process and I have 5 children, and 2 of my 5 children have type 1 diabetes, and they're both competitive bicycle racers. In fact, my oldest son, Peter, raced on Team Novo Nordisk for a whole year. He left his job and raced competitively for a whole year. And both boys are still competitively racing. Now, their mother, my late wife, had autoimmune thyroid disease. So the fact that we have a mom and dad both with autoimmune disorders probably gives rise to a greater likelihood of my children having type 1 diabetes or other autoimmune diseases. So anyway, obviously, you can live with diabetes. Michelle's doing well. I'm doing still well. And I think, insulin requirements, though, are clearly there for the type 1. And I started off with 1 injection for years, had no home glucose monitoring for 25 years of my type 1 diabetes. So it's amazing the tools we have. We have pumps, we have sensors, we have finger stick methodology. Probably the greatest advance in type 1 diabetes since the discovery of insulin is finger stick monitoring, so we can know what our blood sugar is. That wasn't true when I was a child growing up, all the way through my medical school training, my house staff training, my fellowship. It wasn't until right before I came here on the faculty in 1979 was home glucose monitoring capable of being applied. Now, type 2 diabetes is a disorder where the pancreas doesn't make enough insulin. Now, people talk about insulin resistance. So what's insulin resistance? Insulin resistance is why obesity relates to more type 2 diabetes. But insulin resistance is where you need more insulin to do what insulin does. And one thing insulin does is keep the glucose under control. So with insulin resistance, you need more insulin to keep the glucose under control. Now, with type 2 diabetes, as weight increases, insulin resistance increases and insulin secretion increases, but you reach a point when you have a predisposition to get type 2 diabetes where the insulin secretion isn't keeping up with the glucose needs. Actually, insulin does more than glucose metabolism. It affects fat metabolism and affects protein metabolism. We all always use glucose as the metric for type 1 diabetes or type 2 diabetes, but insulin does a lot of good things. All right, so when the pancreas can't keep up with the insulin resistance, then type 2 diabetes develops. Now, with type 2, I think diet and exercise up front will help prevent type 2 diabetes in people who are prone to develop type 2. But then it's the initial therapy. Now, the therapy for type 2 diabetes that's shown to prevent type 2 diabetes and is probably very appropriate for initial therapy is weight reduction. It's not dietary fat, it's not dietary carbohydrate, and exercise can help. But if you're exercising and don't lose weight, there's not much benefit of exercise alone in reducing the glycemic burden in type 2 diabetes. So weight loss is what's important. So that's really a strategy that that nurses and healthcare providers all over the waterfront need to apply to maintaining a normal body weight as long as possible. Once people have gained the weight, really then getting them to eat well, get physically active, and lose weight to reduce the glycemic burden. Now, once, by the way, keeping a healthy lifestyle is important for the ongoing management of type 2 diabetes. There's no question about its importance. But you find that most people with type 2 diabetes don't lose weight very well. But then we want them to eat well, and I'm sure others will talk about that. But this idea that carbohydrate causes diabetes is just ridiculous. It doesn't cause diabetes. And complex carbohydrates is an important aspect of a healthy heart and a overall reduction of risk that come with high saturated fat intake. So fat's not bad, it's just the types of fats. The carbohydrate, simple sugars will raise glucose. So if you're managing your diabetes well, if you have a Coke or a Pepsi and drink it with a blood glucose of 120, it's going to go up a lot and it's going to go up quickly. The complex carbohydrates absorb more slowly and be part of a very good diabetes management strategy. So, in fact, Karen Esposito and her work in Spain has done a tremendous amount of work with the Mediterranean diet, which is the kind of diet that I recommend for prevention of cardiovascular disease as part of our guidelines. Mediterranean diet is meaning lots of fruits and vegetables, lots of whole grains, and lots of lean poultry and fish, and avoiding saturated fats. I mean, this is a type of diet that works as well for diabetes as it does for any other prevention strategy. So back to type 2 and the difference. Type 2 is a defect in the ability of the pancreas to continue to make enough insulin to control glucose. It still makes insulin. Now, the final point I'll make, Judy, is this. It's the rate of decline of beta cell function, meaning the ability of the beta cell to make enough insulin. That slope can be very soft in some people. I've seen people on lifestyle alone or on metformin alone and maintain reasonably good glucose, glycohemoglobins for 15 and 20 years. But in some people, I've seen them deteriorate within 3 months, or people are diagnosed with A1Cs of 14%. And they've obviously not been paying attention to their health. But this rate of decline of beta cell function is one of the most important questions in type 2 diabetes. First of all, why isn't the beta cell able to produce enough insulin to keep the glucose normal? We don't understand the biochemical or molecular defect there. And then secondly, why are these rates of decline so dramatically different from patient to patient? And I think those are really important research questions we haven't answered yet. So I'll stop there.
Okay. Stacy, you want to talk a little bit about diet and exercise?
Sure.
Here, why don't you take this?
I was going to take this because I'm going to stand up because I'm not a very good sitting down kind of speaker. All right, so.
Do you say that I am?
I need more steps, so there we go. We're standing. So I want to make this as interactive as I can. So if you guys, I'm going to ask questions and I will pause until you answer. No, just kidding. So what we talked a lot about healthy lifestyle, which is great, but you can't just tell your patients you need to do a healthy lifestyle. What does that mean? So that's kind of my job, is to kind of talk to you guys about how do you talk to patients about this. So my first question to you guys is there a diabetic diet out there? Who thinks there is? Raise your hand if you think there's a diabetic diet. I see a sheepish little hand over here. So there actually is not anything as a diabetic diet. Like Dr. Eckel said, what we really want to focus on is just healthy eating. And that's what we try to encourage our patients. I try to really, when I talk about food, you want to think food is a very personal subject for patients. It's what we do to feel good. Sometimes we eat to feel good. It's what we do with our families, how we socialize. So eating and food is a very kind of personal subject for a patient. So you want to approach it calmly. And you want to make sure that you don't label food as this is a bad food, this is a good food, because that makes them feel bad if they eat a bad food. But there's good habits and there's bad habits, and what we want to try to encourage is good food habits. So when we eat food, we eat 4 types of food. We generally eat carbohydrates, proteins, fats, and alcohol. And so like Dr. Eckel said, carbohydrates have a really bad rap with diabetes because everybody thinks that carbohydrates are horrible. That's what causes diabetes. But he mentioned complex carbohydrates. Do you guys know what complex carbohydrates are? So those that are higher in fiber, not just made of simple sugars, so they're going to be digest a little bit slower and cause a little bit slower rise in blood sugars. So when we think about carbohydrates, it really comes in couple different types of foods. So we have our starches, so that's going to be your potatoes, rice, pastas, your fruits. Fruits are great for us, but they do contain natural sugars. It's going to be in some dairy products, so milk and yogurt. And then obviously it's going to be in sweets because they're made with sugar. And then we want to think about, I was going to say, so I did the starches. I feel like I'm missing a category. No? Breads, kind of the starchy breads. So those are foods that our patients, we encourage our patients to eat, but we want them to think about kind of the way I teach it is, let's do it in a kind of like a game forum. So we recommend for women to have about 45 to 60 grams of carbohydrates per meal. For men, maybe about 60 to 75. And then what they have is they can portion that out at that meal. So you've got 45 to 60 grams you can eat at this meal. You can figure out how you want to spend that money, those grams of carbohydrates. You want to make good choices because that's what a healthy diet is, but you can spend that much at that meal. Can't carry it over to the next meal. You have to spend it at that meal, but you can spend it how you want to. And then things are going to come up like birthdays. Well, if you want to have a piece of cake for that birthday meal, maybe what you need to do is not eat as many carbohydrates at the main meal. So maybe skip the potatoes or skip the starchy vegetables, but just try to stay within that 45 to 60 grams of carbohydrates per meal. And then kind of just talk to them about, so what are some other good things you want to put in your plate? If you're not filling up in carbohydrates, what else are you going to eat? What would you guys eat for a typical meal? Protein, mix your protein. So with protein, like Dr. Eccles said, we want to just focus on healthy protein. So lean meats, chicken, leaner fishes, turkey, lean beef. So good choices when they're looking at it, because we kind of combine the protein with the fat too. And there's good fats and bad fats. Like you said, our bad fats are going to be your animal fats. So anything that comes from an animal. So that's why we want to choose leaner meats. Bad fats are also going to be some of your tropical oils. There's that huge craze out there for coconut oil, which drives me insane because coconut oil is not a healthy oil, despite what they say. So that's one of my pet peeves. And then all of our processed oils too. So all that trans fat, the government for years said, oh, it's not bad for you. Then they're like, oh, wait a minute, it is bad for you. So we need to remove it from our food. So you really want to focus on looking at unsaturated fats. So that's going to be like nuts, fish, things that are plant-based that are going to be healthier for our patients. And everybody needs some fat in their diet. That's healthy too. So you just have to try to encourage them to add a little bit of the healthier fats in their diet. So not only do I give them this kind of game of you can do 45 to 60 per meal, you can't carry it over and you can't carry it over to the next day, but I also recommend that when they look at their plate, they divide their plate in half. Half of their plate should be some kind of vegetable, non-starchy vegetable, salad, steamed broccoli, whatever it may be, some of the healthy vegetables we have out there. Then if you take the other half of the plate, you need to quarter it. Half of that, or that quarter, should be protein, and the other half can be carbohydrates. That's kind of a good way for them to kind of divide their plate up and look at how healthy they're being at meals. Trying to think what else. Alcohol. We all have alcohol, some of us more than others, because that's how I know Judy, because she's my advisor in the DNP program. So, no, not at all. And when Dr. Eckel was talking about not being hungry and eating, I'm like, I tend to do that when I'm studying. And so alcohol is a part of life. Once again, it's a social thing, and it's not a bad thing for our patients, but we just have to encourage them that some alcohols will raise their blood sugar, some alcohols won't, but it's a high calorie addition to their meals. So if they're really trying to lose weight, maybe not as much alcohol, kind of reducing that. Just to the American Heart Association, the recommendation, 1 glass a day for women, maybe 2 glasses a day for men. So really just kind of talking to them openly about food. And then asking them, well, what are some of your favorite foods? Giving them ideas of, hey, have you thought about trying this instead? And then making sure that you have really close follow-up, because if we just wait and say, we'll see you back in 3 months and see how that diet's going, that's not going to work. They need to have encouragement along the way. So checking in with them. How's it going? How are your changes doing? I also hate the word diet. I really do, because to me, diet means you can't eat what you want to eat. So I never talk to my patients about, you need to go on a diet. It's, let's talk about eating healthy. Let's talk about good nutrition. It just sounds much more positive than the word diet. That's my spiel on diet. Any questions about the diet? And I have a lot of handouts back there. I put some handouts on the table too, so we teach our patients to read food labels and just really investigate the foods that they're eating. A good example for me is I was showing my student yesterday where we're in line. She's like, oh, I'm going to eat take this fat-free salad dressing that was on the salad display, and she's like, this will be healthier for me. And I'm like, well, look at the sugar content of it first before you do that. And the sugar content was twice as much as like a vinaigrette was. So just kind of teaching people to really look at their nutrition. Don't read whatever the propaganda label is on their food, because it's probably just there to get you to buy it, but really get them to look at the label and get into their foods. Look at what they're doing. Now, Dr. Eckel mentioned that we need to lose weight, and he mentioned that the best way to do that is to cut down calories. So the way I try to explain this to my patients to help them lose weight is you have to think about your energy in and energy out. And I think Michelle's going to talk a little bit about that when she talks about her fueling. But that's really what weight maintenance is however much food I put in, if I want to maintain my weight, that's how much energy I need to put out, because our food is our fuel. If you want to lose weight, you need to eat a little bit less calories in, less energy in, and maybe try to move a little bit more. So really kind of focusing on ways to get them up and increasing their activity and reducing their calories. Now, if I have a patient who's overweight and pretty sedentary, do you think I'm going to tell them, you should get up and walk 10,000 steps a day, which is the goal? Is that going to work? No, not at all. So I start with small goals of, how about you get up and walk to the mailbox and get your mail that way instead of waiting for your niece or nephew to get it when they come home from school, or put away the TV remote and you have to get up and change the channel, or every time a commercial comes on, get up and walk around the house once. So just little things to get them up and moving and thinking about how they can add activity in their day. Once again, I try not to use the word exercise, not that exercise is bad, but when people think of exercise, they think of being at the gym, sweating, dying, and be super fit people. And that's not what I'm expecting my patients to do. I just want them to get up and move. So I talk about physical activity. Let's just get up and get you moving. And they seem to appreciate that a little bit better. So one of the ways we do this is through having them set what we call SMART goals. Have you guys heard of SMART goals before? SMART goals are a great goal because it makes them kind of focus on what they're going to do. So be specific, that's what the S stands for, is instead of saying, yep, I'm going to be active. Well, what does that mean? Maybe your activity is, like I said, you want to get up and walk to the mailbox once a day. That's going to be your goal. That's pretty specific. I will walk to the mailbox every day. The next one is measurable, making sure like we add it in every day, making sure that it's something they can do. Maybe we're not going to start with every day. Maybe we're going to start with Monday, Wednesday, Friday, whatever we can do to get them up and moving, but have them set in a measurable part to that goal. The next one is achievable. I want them to be able to meet this goal. So if I would say for somebody who's sedentary, like I said, to walk 10,000 steps a day, that's not going to happen. I want them to set a goal that I know that they can achieve, because I want to give them that positiveness that, hey, you did it, let's try something else. Let's keep going on. And then R is also kind of, they have it two different ways. One of them is or reachable, and then realistic. So that same type of thing of just thinking of, is this something that you can do? Can you do this goal? What can I do to help you reach this goal? Maybe it's giving them a pedometer so they can count their steps. Maybe it's, hey, do you want me to give you a call on Monday to check in, see how your goals are going? What can I do to help you reach this goal? And then then the final one is just kind of a goal that we can kind of go back then and test and look at. How did you do? So when I see them at their next visit, so we set this goal last visit, were you able to do it? If not, why not? And what can I do to help you reach that goal? But never be negative, never that whole part of, well, you didn't reach your goal, well, I'm a failure, because that's what they're feeling. But I'm like, oh, I have those days too. Let's talk about how we can make this better. So always kind of that positive approach to it. What else about diet and exercise? Any other?
I have a question for you. I have type 1 diabetes, and I think pretty much anybody with diabetes is going to experience low blood sugars. Okay, and when you start getting down in the 60 range, you start scrambling around to get some glucose into your body, and you pretty much take what you can get at that point, and then you go into this roller coaster mode where you've taken something to raise your blood glucose level, and now you're getting up over 200 because of that. If you think you've managed it well, but and then you go back down, and you get into this kind of roller coaster trying to keep that under control. Do you have kind of, are there any general guidelines about how to, manage the rescue and aftermath experience?
I can give you kind of what we recommend, and then I can turn it over to our two experts that probably experience this. So what we would recommend is, and I think it's never having experienced a low blood sugar, but seeing my patients go through it, I know it's not a good feeling, and you really just kind of want to eat whatever you can eat to try to bring it up. So I think the hardest thing is really just trying to stay within that 15 grams of kind of fast-acting carbohydrate, simple carbohydrate to raise it. And once the blood sugar comes up, then focusing on something that's a little bit more sustainable. So something that has a mix of carbohydrates and protein, which will digest a little bit slower so you don't get kind of that ups and downs in the roller coaster. And then when you do test and your blood sugar is up at 200, maybe 30 minutes after low blood sugar, just let it ride for a little bit instead of trying to correct it and bring it down, because then you're going to get more insulin in and you're going to get that roller coaster effect. You experts, anything different than that? Okay. I thought I saw another question. For anybody who's nursing students or anything, to remember that in the hospital, especially because when you have that patient who has a low blood sugar when they're in the hospital, they're really likely to have another one that day. So just kind of keeping that in mind. Hmm. It'll kind of depend upon when I give the recommendations, I might adjust that down a little bit based upon how much weight they need to you lose and how active they are. So that's good. If I have somebody who's very sedentary and really not going to be able to exercise, maybe for physical reasons, then I'm probably going to try to shoot closer to the 30 to 45 per meal. We know that we need anywhere between 100 and 130 grams of carbohydrates a day just to maintain brain function. I mean, all of us can relate to that. When you're starving and you're trying to think, you're like, I cannot, because we need that fuel. So it's going to really kind of be patient dependent. And I might start off as somebody who's eating a lot and just go down to kind of that medium range and then lower it down from there. Because it's a big step. If I have somebody who's eating quite a bit of carbs, just say you need to go down to 30, they're like, what? So yeah, baby steps along the way. And Dr. Eichel can attest to this too, is I don't expect perfection. Like if I see my patients generally every 3 months, sometimes sooner than that, I don't expect perfection in 3 months. This is going to be a longer process to get them to make healthy choices in these changes. So really just following along and helping them along the process.
Stacy, I wanted to tell you, when I was first diagnosed as a type 2 diabetic, I was given this formula: one serving is 15 grams, and told I could have around 12 servings a day. And maybe that's not necessarily the best thing to tell a person. But for me, what it did was it gave me an opportunity to see how too many carbohydrates I was eating in a day. So maybe it still was helpful, because for me, even now, because I am active, I probably get more like 15 a day rather than 12. But I think what it does is it points out to you, when it says on the back of the package 15 tortilla chips is all you can have, and you count out 15 tortilla chips on your plate, and then you go, oh my God, I would have sat here and just ate this entire bag. I think it's really helpful to at least initially look at that. I thought that was probably, for me, the most helpful thing. And I don't necessarily am not as anal retentive about it as I used to be, but to at least say, hey, I can't just sit here and eat 10 cookies. If it says, and like you said, if you're gonna eat the entire bag, then you have to compensate. You either have to go exercise, or you don't get to eat for the rest of the day, or you only get to eat vegetables for the rest of the day.
Right. And I think that's really important, because when you start teaching it and you're thinking one slice of bread is 15 grams, and if I can only have, 45, 60 at a meal and I have a sandwich, well, that's half my meal right there. And maybe I want to throw in a piece of fruit, and we know fruit's good, but still carbohydrates. I have an apple, and now I'm at 45, and I got to fill in with something else. So.
The worst shock was cereal with milk. That, if you think that's a healthy breakfast, let me show you how many grams of carbohydrate are in milk and cereal. It's appalling. So I turned to a protein breakfast. I eat a lot of eggs and meat and yogurt with protein, because it was horrifying. I think it's like 4 servings. You have just lost 4 servings over milk and cereal. Is that really what you want to do with your 4 servings? It's not for me, so I don't do it anymore.
Well, and we usually see it raises blood sugars substantially, that cereal. And yeah, we call it the cereal phenomenon. We have a name for it too. Yeah. So we try not to encourage that. So definitely reading the labels. And I was thinking of something else, and then I just lost it. But just having them just look at what they're doing, and really digging in and reading the labels and looking at different foods. And in our clinic, we have a bunch of foods, like empty boxes. Let's look at this. You can look at the serving sizes and really see what you're putting into your mouth at a time. Right. And then Dr. Eckelman showed his smartphone. There's tons of apps out there for people to look up carbohydrates. There's Calorie King app, there's MyFitnessPal app, which is great. And so you can look up almost any, if you're out at a restaurant, you can look up the food for almost anything that they have, and you'll be amazed, because some of them you're like, oh, it's not so healthy. Like, I always thought that I was being healthy when I ate the salad wraps when I went to P.F. Chang's. So much. Not so much.
Just a point clinically, when I see patients and I take this quality of the diet history, it's a good teaching moment. First of all, you have to kind of define whole grains, which you did well at, but people don't understand what whole grains are. And Although cereal has a lot in it, there's no question about the glucose rise we all experience with a bowl of cereal. It really is substantial. And so I've quit cereal for years now, despite the fact it has a lot of whole grains in it. But yet a piece of multigrain bread isn't come close to cereal. So, that's a good alternative for a grain intake for breakfast and get that cereal out of there. Again, cereal's good stuff. The high brand, high wheat cereals are good things. But so if I'm talking to somebody and first of all, potatoes are a vegetable, but if people are eating a serving of potatoes, it's French fries, I don't count it as a vegetable because the saturated fat content, trans fat content of French fries is on the high side. So I don't count that. But, of this size I use frequently, Michelle, in the clinic in terms of how many servings of whole grains and fruits and vegetables they have. And if they're eating, many patients are eating one serving of whole grains. That includes nuts, includes dark rice, includes legumes and other foods that we don't really think of routinely as whole grains. If they're doing one, let's see if we can get them to two, maybe the next time I see them. Now, weight loss, this is my comment about weight, is that, although clinical trials done in research centers like this will show that if you want people to lose weight, if you both have them exercise more and eat fewer calories, when you have a psychologist, an exercise therapist, and a nutritionist involved in the study, you lose more weight than you do with just food intake alone. But in the clinic, it's very impractical to give people an aggressive exercise program or physical activity increase program and also have them eat less. So what I routinely do is I have them do a food diary for 1 week and using an app, go online, figure out how many calories you're eating a day and eat the way you've been eating for years and do that for a week. Then we take 500 calories out a day, and that's a pound a week. And so if the next visit's 12 weeks, I'll set a goal weight. So if they're at 210 now, let's see, in 12 weeks, I'm going to set a goal of under 200. I'll be a little realistic, not make it 198. But so that's often a tool clinically that's helpful in terms of having people reduce weight. And, ultimately, the nadir of weight with food restriction is about 3 to 6 months. So you're not going to get much further with that type of prescription past 6 months. But if you can get them down, then I increase their physical activity substantially because it's been shown that physical activity's benefit is really there to prevent weight regain. And that's where you really can benefit. So in the clinic, don't get patients confused with too much on their agenda. Go at food intake first and make it modest. I mean, if you're eating 2,500 calories a day, you can stand 2,000. I mean, 500 is all, but you'll miss that 500. I'm not saying you would miss it, but think how well your weight's regulated. Most of you in this room aren't even thinking about your weight, but you're maintaining it, aren't you? So this weight reduction is a challenge. If you're maintaining your weight at 210, you're maintaining it there plus or minus 2 or 3 pounds. But now to take 500 calories out a day is a challenge for patients, and you really have to encourage them to really do that. But get a caloric intake for a week first, and focus on food intake alone during the first 3 months, maybe up to 6. And then I'm not saying, Michelle, don't exercise at all. I'm just saying don't make a rigorous physical activity program a mandate up front.
I think he brought up 2 good points too, is making them record their food is huge. If they can write it down, because it makes them much more accountable. So keeping a food log for that first week, but then keeping it after there, because then I do that now and I'm like, oh, maybe, you think, oh, I had a really good day. And then you look back, you're like, oh, I didn't have as good of a day. So making them record their food, I think is really important. And then there was something else you said that I was like, oh.
Well, daily weights to get on the scale every day.
Yeah.
And that's even though, it changes from day to day. I mean, some days you think I'm down a pound, you're up a pound. I mean, but again, you're always up 2 pounds after the weekend, right? It's ownership for your weight and keeping an idea what's going on there.
I was going to say what was scary for me was what's a serving size of spaghetti is a 1/4 cup. That's all you get for a serving. You get a 1/4 cup of rice. So that's amazing. That's your serving. So you can't eat a cup of and you think that's not a lot, but a cup is a lot of spaghetti. So I think you have to really start looking at serving sizes too. I know that I spend a lot of time looking at serving sizes.
I remember the other thing I was going to say, I am not a food Nazi with my patients. I don't, everybody's going to have those days, but the one thing I tell my patients not to do is sugar beverages. There is no juice, regular soda, anything like that. If you cut out regular soda patients, you'll get that 500 calories a week pretty easily, or 500 calories a day pretty easily, and they have no nutritional purpose. So instead of drinking orange juice, eat an orange. So that's the only food that I tell my patients to stay completely away from, is anything with any kind of sugary beverage, because it's just high calories and no nutrition. Oh, yeah.
What are your recommendations for someone who has type 1 diabetes but has a very tight glycemic control, so maybe an A1C of around 6? So kind of I struggle with that, so I tend to run on the low side quite frequently. So then if I were to work out, I would frequently have low blood sugars, and then I would eat and feel like my workout was for nothing because I just ruined it by eating a bunch of food to make up for my hypoglycemia. So is there like a recommendation or maybe a blood glucose range that diabetics should be on before they go and work out?
And Michelle's going to talk a lot about this. So she can probably give you a lot of advice. My advice to patients is, you're right, you don't want to work out if you're trying to be healthy and then eat food, and you shouldn't have to do that. We need to figure out a plan to reduce your insulin for that exercise to prevent those low blood sugars. So really, it's kind of whether you're on a pump or injections or something, but coming up with a plan with your provider that we can kind of lower that insulin and kind of look at your activity and figure out a plan so that you don't have to eat with exercise. That's what I would recommend. It defeats the purpose. And Michelle will have some really good ideas for you too. So.
Do you want your A1C to be 6?
It is 6. So I tend to run on the lower end quite frequently.
Valuable number, because that's what everybody kind of says judges your control on, but that's not the whole picture. So if you're having a lot of low blood sugars, you need to let yourself maybe have or be able to run a little bit higher, because that, I'm guilty of that as a health professional too, as we look at A1Cs when people come in, but you have to remember that's just a number. What's the big picture?
All right. Hi, everyone. So my name is Michelle Shaw. I am a registered nurse because I have type 1 diabetes. So I went to nursing school because I wanted to help people with diabetes. That was why I decided to go into nursing. I have had type 1 diabetes. This November will be 30 years, so not quite as long as Dr. Eckel, but a really long time. 30 years ago when I was diagnosed, my mom, so I was 9 years old at the time, do the math, I know I'm 25. So, my mom was told, honest to God, by a pediatrician where I was diagnosed, good luck with your life. She probably won't live to be 30 and she'll never have children. I might get a little emotional. I'm really passionate about helping people understand diabetes because I've had to live with it for so long. But I can tell you, so I'm 39, if you did the math. And I have 3 beautiful children, all boys, 11, 9, and 6. I had wonderful pregnancies, no complications. I am living life to the fullest with type 1 diabetes. My t-shirt says, it's JDRF, sorry, ADA people, I'm sorry, but get this t-shirt, it's freaking awesome. But it says T1D looks like me, because I don't want people to think that type 1 diabetes is like type 2 diabetes, and I don't want people to think type 2 is like type 1. Both are diabetes. We all have struggles. There should be no shaming of type 1 or type 2, but they're different. They're definitely different. And so with type 1 diabetes, I was an athlete my whole life. I don't know how that happened. My parents are not athletes, but it was just something that I got into at a young age, and I have played collegiate volleyball, played a lot of sports in high school and went to college on volleyball scholarship. I have been on an insulin pump for more than 20 years now. So they've been around for at least 30 years, maybe 35, somewhere years pass. It's been a long time though. They used to be big blue bricks and backpacks that people would wear. I was actually at the ADA and met someone that said, I wore one of those original backpacks. And I was like, holy crap, okay. Um, so that's pretty awesome because, like you said, people way back then maybe aren't even alive today because of how hard it was to treat diabetes before blood sugar testing and even with the first discovered insulins and so forth. So, but I just knew that exercise was always something that I wanted to participate in, and living a healthy life and all of that. So went to college, got my nursing degree, started working in nursing. Some of you may know the Barbara Davis Center across the street. It's a center for childhood diabetes as well as adult diabetes. And I actually worked there for a little while. And then about 10 years ago, I got a job with a medical device company that does insulin pump therapy. So I work for Medtronic Diabetes, so I just want to put that out there as a disclosure to everyone. I just think pump therapy in general is amazing. I don't care what pump people go on, they should get on pump therapy because I think it helps you benefit and be able to treat your diabetes so much more effectively. Not that you can't do it on shots, I just don't want the hassle of all those shots. So I've been on a pump, like I said, for more than 20 years though. So it kind of was my passion to just help other people learn about technology. Pumps today are pretty tiny. This is my pump. So I can hide it if I'm in a formal dress and going to a ADA Father of the Year type event. I can wear a strapless dress and hide this, and it doesn't have to be seen. Or I can just clip it onto my pants. You can put it in a pocket. Women have learned, like, the boots that you can wear, the really high boots. You can just run it down your leg and clip it to the inside of your boots. You can wear it in a bra. You can wear it in the back. You can wear it wherever. Like, it's so easy to wear an insulin pump. And then about 10 years ago, continuous glucose monitoring, or CGM, became available to patients with type 1 diabetes. Both Dr. Eckel and I wear CGM, and I think it has been a life-changing device for me, even more so than the insulin pump. Yeah, so it's going to give a reading, and there's a couple different brands out there. But I can look here and see that my blood sugar is 140 and slightly rising, but not dramatically that I need to do anything about it. I could also see that before we started this event, my blood sugar was dropping, and therefore I kind of took some glucose and different things to prevent me from having low while I got up here to talk. So it's a tool to help you better manage your diabetes. It's not a cure for diabetes. None of what I wear is a cure for diabetes. I still have to take insulin, right? You all, well, those without diabetes in this room, you get insulin all the time from your body. Thank you. It's awesome. I don't. So this is how I get mine, and I'm really proud that, I'm able to manage my diabetes with technology. So it's been really helpful. So that takes me to exercising. And like I said, I've always been an athlete and had always been pretty fit. And then I got pregnant. Then I wasn't fit anymore. And I became a mom. And I did not feel like myself. And I think this is things that women that you definitely connect with in clinics who are moms that have type 1 diabetes, a lot of them will probably feel this way. But you lose your body, you kind of lose yourself. I mean, all moms know that your kids come first, and that's what you do. And so after my first kid, I tried to lose the baby weight. And I, a little bit, but then I got pregnant again. Like, I had a baby, nursed for a year, got pregnant. Had a baby, nursed for a year, got pregnant. Had a baby, nursed for a year. So 6 years went by. And not that I ever got where I was really uncomfortable overweight, but it wasn't me. It wasn't the athletic body I was used to. It wasn't just feeling like myself. And so about 3 years ago, I really just kind of took the plunge that, my youngest is now 3, I need to get my life back. And so I started running. That was a whole new adventure for me. I was a volleyball player. We don't really run. We sprint on the court. We dive. We jump. Running, I wasn't quite sure it was meant for me, but I did it because I thought that's going to be an easy, cheap, healthy way for me to get out there and get fit. And I actually kind of enjoyed it. It was okay for a while. And I started, I'm very competitive, even with my own children. We battle all the time on board games, and they play baseball, and I have to out hit them, and that kind of stuff. So I'm very, very competitive with myself and other people, and so my children. I'm sorry. So when I was running, I kept like challenging myself to go further, like run farther distance, but it was such a challenge with my type 1 diabetes because I wasn't understanding, and never through growing up until just 3 years ago, really. And I'm a nurse too, but did I understand how food was really helping me in my athletic life? I never really understood it in college. I didn't understand it as a teenager growing up playing sports. And so I've really, over the past 3 years, learned a lot about how nutrition fuels my body in different types of activities and what I need to do while I'm doing different types of activities. So I ran, and I started to sign up for some different races. Started with a 5K, then went to a 10K, and like all those local things around here. And then someone was like, "Hey, I'm signed up for the Rock and Roll Half Marathon, and I can't run it. Do you want to run it for me?" And I was like, "No, I'm just a beginner runner. I can't run 13.1 miles." She's like, "Too late. You're going to do it because you need a goal." And that goal is what actually made me start digging into how to treat my diabetes. And so I will tell you, if I did not have continuous glucose monitoring, I think it would be extremely difficult to be able to understand and manage my diabetes while I'm in the middle of activities or sports or running or whatever. And so for me, it's a lot of trial and error. So what I'm telling you guys with diabetes and stuff that Stacy was saying, it's not black and white. It's not just take this pill. Well, for type 1, it's not just take this pill and you'll get this result. You can line 10 diabetes educators up in a room, and you will get 10 different results for the same case study, because it's more of an art. It's more of a trial. It's more of a kind of try this and see if it works, and let's adapt and change as we see the results from it. And so that's what I did myself. I was not in any kind of study or anything like that. I just said for myself, I'm going to go out for a 3-mile run. This is my starting blood sugar, and I would keep a log, and I would say like what I fueled with that morning, and I'd watch kind of my CGM, and when I'd get home, I'd kind of take notes on it. And it was interesting. If I started with a great number and I went for a fasted run, so I ate nothing before I went, I wouldn't have a low necessarily while I was out running, but within the hour, guaranteed I was going to drop, unless I came home and fueled my body. So what does that look like? It doesn't have to be fast-acting carbs at that time. It can be protein. It can be a well-rounded, balanced breakfast with some protein, some whole grains, and some fruit. And that's what or some yogurt I often did as well. And so I don't know. Over time, I learned how to manage. Look, I'm trying to get my steps, by the way, because my kids are going to beat me. But anyways, told you we're a very competitive family. My husband played football, so my poor kids are just screwed because they have the athletic genes in their body and they're competitive as like we are. But oh, I forgot what I was saying. What was I saying before I said my kids are screwed? That I ate after I ran. Yeah. So just over time, I started learning how different types of foods, different distances would do different things to my blood sugars. I run with a waist pack so that I can carry my blood glucose monitor with me. I will just say that most of the time I don't use it. I go off of my continuous glucose monitor, but I was out on a long run, on a training run for a race, and I was just like, it started to like be blurry in my vision, and I just remember like, holy crap, what's going on? And my sensor was saying that I was low, but it wasn't picking up how low I really was. And when I tested, I was under 40, and I'm by myself out on a run. So what do you do when you're low out on a run by yourself? So I actually will travel in my in my waistband with pure glucose gels. So this is the old version of it. They've now changed to this version by the company makers. But these are 15 grams of fast-acting glucose. I had to stop my run. I was not happy. I had to I had to stand still for a while, and then I had to take my glucose, and then I was able to kind of start walking. Thankfully, my husband does also have a device that can be alerted to me when I am low. So he was able to text me and say, "Hey, are you okay? You know, what's going on?" And I could say, "Yeah, I've treated. My blood sugars are coming up. We just have to give it time." And that's the hardest thing when you have a low glucose when you're exercising, is giving it time, because you want to finish your activity, but now diabetes is stepping in and saying, stop, wait, no, you got to take care of me first. And you're not always happy about that. So I get my blood sugar back up, and then I continue on with my activity. I also know that my blood sugar, I will sometimes take 30 grams of carbs, because I'll know that my blood sugar is going to keep rising, and I'm going to keep working out, which is going to cause a low potentially after that. So there's different scenarios that play out that you guys can certainly ask questions about, and I can tell you what I do, but again, it's different for every single person. So I was running for about 2.5 years. I actually did my first marathon last January, so a year and a half ago, just because I wanted to say that I had type 1 diabetes and I ran a marathon. No other reason. I didn't enjoy it. I really don't want to ever run 26.2 miles again. What? Yeah, it's horrible. Like, your body hurts the whole time. I did do it at Disney World on a family vacation, so I would consider doing another one at Disney World if I got to go on vacation again, and you get to stop and pose with the characters, so it was great. But no, I would not just go out and like run the Colfax Marathon. No, not going to happen. So, but it's a lot of prep in order to be successful as an athlete with diabetes. It's just, you're constantly thinking about it. That's, I guess, the one thing I want you guys to know, at least from my point of view with type 1 diabetes, is that this disease is 24/7, 365 days a year. When I go on vacation, diabetes comes with me. There is no vacation from type 1 diabetes, ever, for anybody that has it. Kids, parents of kids, my spouse, he thinks about it constantly. He worries about me constantly. It is a life-changing disease, but it is a disease you can live with. You don't have to let it define you. You can say, this is my life, and diabetes is coming along for the ride. At least that's how I like to look at it, and how I like to try and have my patients understand that you don't have to use diabetes as a crutch or an excuse. Yes, there's other things you have to plan for, but same for someone that wears glasses. If you go out without your glasses that day, are you in trouble? Probably. If I go out without my insulin pump, am I in trouble? Yeah, right? So it's just about the perspective a lot that you have on diabetes, on how people manage it. And it's hard. It is a grueling, hard, everyday disease that you have to deal with. And sometimes people will be riding a high. Like, we just got back from ADA Camp Colorado, which is type 1 diabetes camp. We're always looking for students to come and volunteer, so I'm plugging that now. But it was 275 kids with type 1 diabetes, 100 volunteer staff who are, some are doctors, some are diabetes educators, some are nursing students, PA students, MD students, all kinds of students. Some are parents, some are siblings, like older siblings of their young kids. They all come to volunteer for a week. And this is at a camp that is at 9,500 feet elevation. It has a zip line and a lake and a canoe and kayaking and riflery. And I mean, it has everything normal kids would do if they didn't have type 1 diabetes. So why can't our kids do it too? And so when you come off of camp, it's just an amazing family. And when you come out of camp, everyone that comes out of camp is like on this diabetes high, right? Like, we're all feeling like rock stars. We're tired, it's a little sick, still getting over that, but it's just amazing. But there's going to be times this year in 2016 where I'm not feeling like a rock star, you guys. I will be down, kind of like in the, oh, screw you, diabetes, like, Seriously. And those are the realities that your patients are going to be going through. They're going to have ups and downs. Our blood sugars are a roller coaster, but so are our emotions surrounded around it, and so are the emotions of the loved ones associated with that person. So we usually call that type 3 diabetes, unless they've now discovered another type of diabetes, which I kind of heard something about, maybe. So 7. Yeah, so it's crazy. But I used to call it, before there were 7 types of diabetes, it's not final yet. Okay, so type 3 was for your significant others, your family, your support ones, right? That's, we called them our type 3ers, so that they were type 1, type 2, and then the type 3s. But I'll stop talking because I think you guys might have some questions specifically about exercise, insulin management. I guess I'll wrap up with one thing. So I actually changed my exercise routine a year ago from running, because as much as I was doing great things for my cardiovascular side of things, I was not losing any weight. I was just really maintaining. I wasn't fit. I didn't feel fit. I was just kind of like what I call the skinny fat, if you will. Like, it was like I had fluff everywhere, and I just wasn't back to myself that I was previously. And I know I'm 39 years old, and I may never have back to that 20-year-old self, right? That's fine. But so I started lifting weights about a year ago, and I started lifting heavy weights about 4 months ago, because I am competing in my first fitness bikini competition next Thursday. So I'm leaving a week from today, and I'm really scared crapless. But it's just, someone put it out there as a goal, and I said, why not? Let's try it. I will be in a bikini with my insulin pump and my continuous glucose monitor. So, but I'll show you, like, I've got some guns, right? Like, I got muscles. I've been working to build that. But here's the thing. Those muscles came with a lot of tears over diabetes, because it's different than cardiovascular working out, right? So it's different than running. I had to completely change my fuel. I had to completely change my eating habits. I had to completely change how I was taking, not how I was taking my insulin, but how much I was taking in my insulin. There's different stages in this process. And so it's been almost 120 days that I have been dedicated, specific, lean food. My dinner tonight is with me because I have to eat on certain time schedules. But here's some cod and broccoli. Yes. I prep this ahead of time. I make my food and take it with me. This is how I'm able to be successful. I'm not saying all your patients are going to do that by any means, but I take, veggies. I've got protein bars. I've got my glucose with me. I do protein shakes, and I drink a lot of water. So it definitely changed how I was focused on my diabetes in the last 4 months than I had for the prior 2.5 years with just being a runner. So I kind of stopped running, and I'm only lifting right now because it breaks down my muscle. So anyways, questions. What can I answer for you? I know you had some questions. I don't know if I answered quite most of yours. Okay. Helpful? What scares you the most about type 1 diabetes with your patients or people you might encounter? Huh? The low drop. Yeah, it scares your patients too, for sure. Some patients have had such severe lows that they refuse to run under 200 now because of it. People can have seizures. It's dead serious. Like, people will run in the A1Cs of 8, 9, and 10% because they're fearful, extremely fearful of a hypoglycemic event. On the other hand, I hate highs. I hate them. I know it's really bad to say, but I would rather be between 60 and 150 than above 150. Okay, 200. I'll be safe. 200. But I just feel at my best when I'm there. But my A1C for the last, go back to getting, before I got pregnant, I had to be in good control to plan my pregnancy with my healthcare provider. And my A1C had to be under 7% in order to get pregnant. So my oldest is 11, and I was pregnant for 9 months before he turned 11. So, you know, I have not had an A1C over 7% in like 12 years. Right? So my body has adapted to that. I do run on the lower side quite often. I use a lot of temp basals on my insulin pump, so I decrease insulin depending on the type of workouts that I'm doing. But I also see, especially because I'm competitive, adrenaline causes a huge spike in my blood sugars depending on the type of workout I'm doing, especially when I'm lifting weights. I can wake up and start with a great blood sugar of 104 this morning after a threshold suspend during the night. Threshold suspend is when my CGM determined that my glucose value was under 60, and it actually shut off insulin delivery on my insulin pump, and it stayed off for 2 hours. My 9-year-old got up to go to the bathroom around 4 a.m. and came in and was like, Mom, your pump is beeping at you. Because it sirens the entire 2 hours. But I went to bed at midnight, and I was supposed to be getting up at about 4:45 to work out, and I was just exhausted. It's been a long couple of weeks with camp and Keystone and just nonstop diabetes work. And so I was exhausted last night, and I did not hear my alarm go off, but I had something that took action for me and turned off my glucose value. When I tested at 5:15 this morning, I woke up a little late, and it was 104. So, yay, I woke up, because nighttime hypoglycemia is the biggest fear for most people with type 1 diabetes, that they're not going to wake up in the morning. And there is something called dead in the bed syndrome, which is where people go to bed just fine when they went to bed, and they never wake up in the morning. And it was from a hypoglycemic event. So, typically. So that's probably my biggest fear too, right? And so I have this tool that'll turn off my insulin. And I tell you that just because I want you to know things are available and only going to continue to get better for people with type 1 diabetes where technology is concerned. And so I was able to, you know, start my workout this morning and have a great workout. But when I finished it, I was over 200. Could it have been because my insulin was turned off for 2 hours? It could have been. Could it have also been because I noticed that when I do the leg workouts, who wears heels on leg day? Seriously. But anyways, the leg workout that I did and all of that was just so intense and such heavy weights that I see an increase in my blood sugars. Do I correct for that? Not normally the full correction. Sometimes I'll do half, sometimes just a third, because sometimes it's just a false high, if you will. It says you're high on your meter, but as soon as that adrenaline kind of exits your body, your blood sugars are going to come back down, typically on their own, sometimes with insulin, depending on how high you get. So those are just some of the things that I experience. Any other questions? Yeah. When I was a runner, I ate anything I wanted all the time. I'm going to go for a 10-mile training run. I deserve a double cheeseburger with bacon. I'm not kidding. I thought I was being healthy because I ran 10 miles, right? Like, my body deserves some fuel. Wrong, right? So I didn't do that every time, Dr. Eckel. I said that one just for you, actually. But when I decided to do the fitness and bikini competition, there are 3 steps to that process. There is a build muscle phase, there is a bulk muscle phase, and there is a lean out phase. And the build is obviously what it sounds like, where you want to build that underlying muscle and start to work to build that up. And my calories, so before I started that, my calories were right around 1,800 to 2,000 when I was kind of still running. When I started the build phase, I was at 2,200. When I went into the bulk phase, and I count macros. So Dr. Eckel was talking about how macros are really important with protein and fats and carbohydrates. And so I do different splits in all of these, and I'd have to go back and look at, I use my Fitness Pal. But I have logged everything for literally almost 120 days of food that I eat and what percentage of proteins do I want and carbohydrates and all that kind of stuff. But when I got into the bulk phase, that was when you can like eat a ton of carbohydrates and it's not bad for you because you're trying to bulk up and really put on a lot of that muscle and you need fuel for your muscles to grow. So I was at 3,400 calories and I only put on 7 pounds in 9 weeks. So I was just working out every single day. I had one rest day, so 6 out of 7 days a week. I was lifting heavy and I was eating a ton of food. Carbs was at 50% macros, and then protein was at like 30%, and I think fat was at 20% at that time. And then as I transitioned into the lean out phase, it's really high protein now, followed by fat, and then low carb. So I'm right around that 80 to 100 grams of carbs a day for my lean out phase. But I'm trying to stick to 100 so I don't develop ketones, which are not safe for anybody all the time. I don't know, what's your take on the keto diet? Not good? Yeah, I'm not doing it. Trying not to do it. Yeah, I actually had to check at diabetes camp because I felt miserable. My blood sugar was 147 and I had 1.6 ketones on a blood ketone meter because I had not had any carbs yet for the day. As soon as I put carbs in my body and took a little insulin, I was fine. But yeah, so I'm checking ketones. Yeah, questions? I think I'm done because you guys are here way past time, I think. No? We're good? Yes, more questions. Oh, yeah.
So I'm going to have a different take because I'm a type 2 diabetic. I was an athlete. I've always been this size. I've never been 300 pounds. I didn't get diabetes because I overeat. I got type 2 diabetes because my mom is a type 2 diabetic. I never thought I'd be an advocate for type 2 diabetes, but my experience of the past 4 years has been interesting at best. So 4 years ago, I was trying to join the wellness club over here, and this little guy, who at the time I thought was 15, I'm sure he was 20, said, "Oh, your blood glucose is way too high." And I'm like, no, it's not. He's like, no, it really is. It's way too high. You need to go have this checked. And so I went in, and for those who may or may not know, I know they've been talking a lot about A1Cs, but 6.5 is that cutoff point where they consider you a type 2 diabetic. I was at a 6.4, so I was right on the edge. I was considered a pre-type 2 diabetic. And I guess the reason I want to be an advocate is I went in to see my physician, and she said, "Oh, let me just write you a prescription." And I said, "No, you're not going to write me a prescription. Let me change my diet." And the other thing, I guess, I was really irritated was that at the time I was running triathlons, I was doing things like that. You need to exercise more. And I'm like, ugh, I'm already doing 10 to 15 hours a week of exercise. That's not what I need to do. And so I made a deal with her that I would try and change my diet and come back. And so when I came back, I was down to a 6.1. And that was really great, except that I'm at a certain age where my hormones went all kind of wacky. And so all of a sudden, without doing anything different, my A1C pops back up. One of my very bright students came in my office one day and said, "You know, Judy, I see that you're fighting going on medication. It will help you." And I said, "I don't want to take medication." And she said, "You know, if you had cancer, we wouldn't tell you go home and diet and exercise. We would tell you that there are medications that would help you." And so I said, "Okay." So I went back to my physician and I said, "Will you send me to endocrinology? I want to go." So that's where I met Erin Meyerhoff, who works with Stacy. And that started my kind of my direction on what I'm doing. Erin and I have this interesting relationship. I don't know whether this is Erin's personality or just how she knows that I work with her. Because I went in and I said, Erin, I don't think I can lose any more weight. This is really tough. She goes, maybe you won't. I'm like, what? And so I proceeded to say, okay, fine, I'll show you. And so I had, even before I was diagnosed, Michelle and I did the same half marathon. I did the full marathon. I did the Disney Marathon too in 2008. I have done triathlons. I've done 2 years of Ride the Rockies. And so for me, this was really painful. This hurt a lot. This made me really, really mad. How did I deserve type 2 diabetes? I exercise. I try really hard to eat right. And so I'm here to say that I believe in moderation. Do I once in a while have a full strength Mountain Dew? You betcha. Um, do I have, and these guys, some of these are my coworkers, do I have 3 little peppermint patties every single day? You bet I do. But have I overall changed my diet? I have. I do drink Diet Mountain Dew. Because I have to have that caffeine. But I do watch, and even though I get to maybe once in a while not worry about it, but I think about my diabetes every single day. I think about how I'm going to exercise. I think about how my exercise is going to change what I'm doing. I was telling these guys earlier, I attempted a half Ironman last year, and I had a little sugar low and a little breakdown between the bike and the running portion. I sat in the transitionary area. I got the wrong shoe on the wrong foot. I'm all weepy, and my friends are saying, "Here, eat this little peanut butter and banana sandwich. Take your time." And in 20 minutes, I got up and ran 8 more miles. I didn't finish it. I had 65.3 out of the 70.3 that I finished. But again, I'm with Michelle. There is no reason that a type 2 diabetic can't exercise. The one thing, my big thing right now is not to shame type 2 diabetics. I have no control over what my body has decided to do. I can, however, change what I do and change my diet. Listening to Dr. Eckel just depresses me even more, because as a type 2 diabetic, you're worried about cardiovascular disease. You have all kinds of comorbidities you have to worry about. I want to stay under 6.5 for the rest of my life if I possibly can. I only take 1,000 milligrams of metformin. The max is 2,000. I want to stay like that for the rest of my life if I can. I want to stay active. I already have cardiovascular disease in my family. Everybody drops dead of some kind of heart disease or a stroke. So I already have the double whammy of heart disease. Yeah.
Judy, are you on a statin?
I'm not, well, so, so let me tell you my story. Erin and I have been fighting about a statin for a year. So she put me on Lipitor, 40 milligrams, and my legs ached like a son of a gun, like I had been running 10 miles a day. We're going to talk in October. We wanted to get that off. But we're going to try something else. I know. She laughs at me because I argue with her about the metformin. I find when I started, I only went on 500 milligrams of metformin. That's the lowest you can go. And that was really great for a long time. And then she's like, "You're going to have to up it." And I'm like, "Okay, fine." So I'm only at 1,000 milligrams. My last A1C was a 6.3. I've had it as low as a 5.9 when I was training for an Ironman, but this summer has sucked. I will tell you that right now. I've not been able to exercise as much as I want. I've gained a little weight back, and I'm not very happy. And I'm with you. But you know, it's not that bad as long as you are thinking about moderation. You're thinking about service sizes. Do you really need French fries when they've got coleslaw? You make substitutions. You find, oh, come on, coleslaw's really great, especially when it's, well, I know, but it's better than a French fry. Well, side salad, you have to make trade-offs. So I'm here to say that type 2 diabetes is not a death wish. It is not something to end your life, but you do have to take care of yourself, because what worries me more than anything is that phrase, died from complications from type 2 diabetes. That is what I fear. And I want to stay as healthy as possible, because I don't want my toes amputated. I don't want to go blind. I don't want all my teeth to fall out. And so you got to take care of yourself. So if you're on the edge of pre-type 2 diabetes, or you got a family member, I'm here to tell you that life is not over, and you can continue to be active or get active. Any questions? Yeah, Ron.
So previously, ADA had some researchers talk, and one of them was talking about, I think it was exercise intolerance for especially type 2 diabetics. Does anybody on the panel or anything like that have information about that? Because I guess I'm curious what might be. They were saying that I think it was harder for them for people with type 2 diabetes, especially, to get more active and to have kind of a exercise program. But I don't really recall that they had much information other than they were researching.
Of course, I'm happy to hear that. That means that because I'm so slow, that I can blame that on my type 2 diabetes, right? I am slow because of my type 2 diabetes.
Yeah, the question comes up of, is there something unique about type 2 diabetes that makes someone exercise intolerant? The term would need to be defined, and there's so many issues that could enter in there. I mean, it could be neuropathy, it could be vascular disease, it could be just the weight maintenance scenario that goes along with obesity. Maybe type 2 diabetes complicates this a little bit. I mean, Judy Regensteiner and Jane Ruscher have done a lot of work in exercise and type 2 diabetes, and basically the training effect can be a little more limited in type 2s, and the issue is that the heart, or is it the muscle on using fuels? And I think that's an area that's still totally uncertain, but it's probably more related to oxidation in the muscle in terms of the fuels, the way they're burned. But that's a vague statement. This is not a clear area, but I think our job as healthcare professionals would be to go ahead and have these people maybe get more formal evaluations in terms of their exercise tolerance. And I think Stacy said this, maybe it was Michelle, but you begin slowly and try to ease people into a more active lifestyle. But the exercise intolerance term would need to be defined. It has to be individualized, because there could be a lot of etiologies for that.
Well,
By the way, statins can cause more symptoms with exercise. I mean, so you're not unique, but everybody on adequate doses of statins don't have exercise intolerance. But it's clear that the exercise can exacerbate that and make it more common. So what you've experienced is not rare. Yeah.
Well, I just don't see any high performance type 2 diabetics. Is that because you aren't diagnosed as a type 2 diabetic until later in life, potentially? You're already past your prime. I'm certainly not going to break any world records in my, marathon speed either.
Yeah, but you're an icon for this, and I think it's important to show that you can do it. And
You can do it.
and I think maintaining an active lifestyle is good for your heart. It's good for your diabetes control. It's good for a lot of things. So, and weight, keep in mind that exercise and weight don't change. I mean, exercise alone, you got to really be incredibly elite to lose much weight with exercise. So don't have overly high expectations in that space.
I did, when I was training last year for my half Ironman, I did lose about 9 pounds. But I was doing, riding 50 miles and then going for a run for 3 hours. So you are talking about all day. But yeah, and I haven't quite figured out that trial and error to not have that meltdown.
So Judy, let me kind of paint the scenario of a clinician taking care of sometimes very complicated people with type 2 diabetes. I always start with lifestyle in terms of trying to get people more active and also getting their nutrition worked out. And that includes, a good mix of complex carbohydrates, good fats, if you will. I like good and bad for fats, Stacy, but I don't like it for foods.
Right. That's what I said.
Yeah. But for foods, there's nothing wrong. I have one rare or medium rare steak once a month, but I don't have it 4 times a week.
Right.
I might eat fast food once every 3 months, but I don't have to confess that. I'm just doing it rarely. Having a diet ownership for a heart healthy diet is really important. The next step is A1C control. So past lifestyle, A1C is next, and then risk factor modification. If blood pressure's up, that needs to be treated. And if in fact you have type 2 diabetes, you should be on a statin. So work with Aaron on that. I think it's important to try to find some dose you can tolerate and still do your activity. And beyond that's assessing for complications, retinal exams, foot care, and urine dipsticks for protein and all that kind of stuff's routine. Weight is on near the end of my list in terms of in patients with type 2. That doesn't mean losing weight wouldn't be helpful, but weight loss is down my list in terms of what we know about complications in diabetes. So.
Right.
Keeping it off is more difficult. That's an area, by the way, that this campus is really known for. Jim Hill, myself, Paul McLean, many people at this campus are interested in reduced obesity and what the biology is of predicting weight regain. So again, the message for obesity is prevent it to begin with. And I think that's really relates to each of us individually and the families and our whole behavior day in and day out going forward. That's why getting on the scale for all of us is probably a good idea. Just make sure we're maintaining within our weight maintenance range. And losing weight's a whole different paradigm. So.
Any questions? Yes.
This one is more for Dr. Eckel. Can you speak to the gut microbiome and type 2 diabetes? Any recent research or findings on that?
An area of active research, kind of the bacteria we have in our intestinal tract really relates a lot to metabolism. And this is a field that's rapidly, expanding now. Whether or not diabetes itself is so related to it, but there's a fair amount of evidence that the gut bacteria do control energy balance. And the mechanism by which these microbes in our gut really influence our metabolism is really still not totally understood. I should say that, ultimately now, C. difficile, people with, ultimately drug-induced bowel disease and have, C. diff ultimately can be treated very favorably with fecal bacteria. You don't eat the stool, but the idea of giving the microbes that are present in stool can sometimes be very remedial for that condition. But in terms of therapeutics, we're not there yet, clearly. There's a lot of research that's ongoing, so be patient for that one.
So one thing that I have discovered myself is active cultures. So this is an interesting thing that I've noticed recently, that I take my blood glucose twice a day. Twice a year, twice a day. Yeah, you're gonna have to talk to Aaron. Twice a day. And so I take it around 9:30 before I go to bed. And so I'm hungry at 8 o'clock at night. And so for whatever bizarre reason, my husband brought home some Noosa, which of course I was like, oh my God, look at all the sugar in this. And so he bought these little tiny ones, the little 4-ounce ones. If I eat that at 8 o'clock, at 9 o'clock, my blood glucose is at 111, 110, 112. That is unheard of usually after dinner in the evening, I'm around 140, 150. So I'm a firm believer that there's something going on with the cultures and the gut, because I'm finding that to be very, very helpful for me. And I eat a lot of yogurt.
But the data just aren't there to support that. That doesn't mean
That's-
you're not experiencing something. It's just that
Yeah, exactly.
probiotics and prebiotics in terms of clinical trials with diabetes have not been
Right.
successful at this point.
So I want to again thank everybody for coming today. If this excited you at all and you want to start exercising, we have we've asked the Boulder Running Company to come on Friday from 12 to 1. They're doing a free seminar on how to do your first 5K. We were laughing because I'm going to bring cookies. But you haven't started your 5K training yet. So they have this whole thing on how to get up to your first 5K. So if you're interested in coming, it's free and open to the public. But I wanted, because it was such a great opportunity to say, you know, exercise is your friend. It's not horrible. But I really want to thank Dr. Eckel and Stacy and Michelle for coming tonight. And thank you all for coming. I really appreciate it. I hope you enjoyed it and got some good information from it. Thanks.
And thanks for the lovely T-shirt.